Good morning, doctors. My name is Meng. I'm the Business Development Manager with EMED Asia. So thank you so much for dialing in this morning and coming here to get some information about this neutralizing antibody that we are going to be that Dr. Diana is going to be sharing with us. So just a very simple housekeeping message. I hope everyone will be able to keep their microphone on mute unless there's any questions to be asked, so that we can reduce the background noises. Okay, so just a very quick brief introduction. EMED Asia, we do have this system in place for doctors where they can request for lab tests through EMED Asia to the labs. So we are in a very strategic partnership. It's something very exciting that we are embarking on here as well, with this brand called ImmuSAFE and a laboratory, Neogenics. Right. So our speaker today will be Dr. Diana. She'll be introducing ImmuSAFE test. She is from Sengenix. So the main thing that we will be talking about, of course, would be ImmuSAFE's role as a neutralizing antibody test. And I think the biggest question that all of you have would be, what's the key differentiation of ImmuSAFE test compared with all the other options available in the market? So yeah, I think Dr. Diana would do a good job, updating you on all this product information and differentiation. So over to you, Dr. Diana.
All right, thank you. Let me just try to share my screen. It trying to get grant access to me, from me. Just use. Share again. All right. Finally. Can you let me know if you can see my screen clearly?
Yes, we can.
Hang on, I'm sharing the wrong desktop here. Let's try this one. Share. Problem with Zoom is that it will ask for your permission every time for every meeting. So just bear with me. Right, you can see the second desktop, yes? You should be seeing ImmuSAFE COVID chip.
We can see it now, the COVID plus biochip. Yes.
All right. Let's move this now. Right. At this point, have the participants been briefed on what ImmuSAFE COVID biochip test is, or have not?
We did send out a mailer maybe about 2 weeks ago with some information from a press, press release. But it'd be good to go into the details as well.
Yes, of course. Right, ImmuSAFE COVID biochip test. This is a Sengenix protein microarray. As you know, Sengenix is a protein microarray company. We specialize in functional proteomics technology, and our main product, our only product, is actually protein microarray. Our expertise lies on protein expression and fabricating those protein, or some people call, in layman term, is antigen on a protein microarray chip. So protein microarray based, in compared to ELISA, it adapts a similar concept as ELISA, but in compared to ELISA, you are able to multiplex your test. For ELISA, you have one antigen per well, whereas in protein microarray, you can fabricate as many as antigen as possible. The maximum capacity that we have in one of our product is 1,600 proteins in one slide. So that slide is the size of a standard microscope slide that you commonly use in your histology. It's just that it is fabricated using robotic pin to make a droplet of protein. So one spot that you see here, one spot here represents one antigen. So for each antigen, it is fabricated in triplicate. So the data are produced in triplicate. And when we analyze and we develop algorithm to analyze each antigen, it is still already considered a statistically powered data. So for ImmuSAFE, for ImmuSAFE COVID plus biochip, particularly, we have the spike antigen on this chip. There are 3 domains, full length and also numerous truncated version, but at this point, we are focusing only on the full length. I know you have been briefed that there are several truncated versions of spike protein, but biological and also scientifically, we are focusing on full length spike protein because it represents the actual conformation of the virus rather than having it truncated into various domains. We have 6 truncated nucleocapsid proteins on this array. And also we have other non-viral protein that related to immune response, which can be used as an indicator to predict disease severity or disease progression. So those non-viral protein included in the chip are anti-nuclear antibodies. Antigens represents from in the anti-nuclear antibodies group, interferons and also tumor necrosis factor. So the difference, I would say, is the multiplexing and multi-antigen content that you have and the information that you get in compared to ELISA, which is our closest competitor here. And the information that you get is much more thorough and is much more in-depth in regards to what is happening inside your body following infection or vaccination. So just a brief explanation of the technology from CRAX, technology that Syngenix adapt. So basically, what we do, just to make things much simpler for you to understand, the difference between our platform and other ELISA platform, we do not purify our protein. We use a surface capture technology to fabricate the protein onto the array. So one must wonder, so what about unspecific binding that you may get, right? Following, if you produce antigen, you put it in any cellular-based system, you express the protein and then you purify. That is the common method how people used to develop a serology-based test. Whereas for this one, when we produce our protein, we clone it in frame with this molecule called biotin. And biotin interactor is streptavidin. So biotin and streptavidin has the highest or the strongest covalent bond known on this planet, known so far. So we take advantage of that interaction to fabricate protein that is only biotin-related. So because the biotin is cloned in frame with the protein of interest, only protein that are correctly folded will produce a correctly folded biotin domain, which will produce biotin. So this biotin will be captured by this surface that is pre-coated with antigen. Those proteins that are not correctly folded will be washed away by just simply washing step as what you would normally perform in any serology or histology-based experiment. So that's the main technology of Syngenix, the correctly folded protein and also the surface capture technology, which avoid protein purification method that could jeopardize the conformation of the protein, consequently jeopardizing the true biological interaction between antigen and antibody that could recognize the fabricated antigen here. So moving forward. So ImmuSAFE is a fully quantitative assay, meaning we can tell how many, we can infer how many, the reciprocal titer value of the antibody in any given tested samples. You can use serum or plasma to test on this platform. And per slide, we have 24 subarrays, which means if you familiar with the microscope slide, normally in any immunohistochemistry, you just put one sample per slide. Whereas in this case, in ImmuSAFE case, you can test 24 samples per slide. So, and the assay, you can adapt, you can employ the single color or dual color fluorescent based assay. And it's a system compatible with any microarray scanner, but the one that we use is Agilent. But any lab that has this format of scanner is adaptable with our platform. So I think with the mass vaccination that going through now, the only question that people ask now is, do I have neutralizing antibodies following vaccination or infection? That's the only question that wherever I go, people will ask. ImmuSAFE, in compared to other tests, because of the presence of multi-antigen on the surface, we managed to increase the specificity and the sensitivity of our test. And this is a comparison of our performance between ImmuSAFE and other commercial serology tests available on the market. And as you can see, this is just a representation on how the samples that are called negative on other platform, which labeled as 0, and there are borderline samples here, are called positive on ImmuSAFE. So we managed to capture those false negative samples that were called by other serological tests. And we have published this data where we quantify. This is the data is generated in conjunction with in collaboration with IMR, and we have published this data where we quantify the antibody titer. This is following natural infection between patients, post-COVID infected patients of various ages, and we found that as the age increases, the antibody titer also increases. And a good thing about ImmuSAFE is we can also quantify the coverage. This is based on N protein. Earlier I mentioned we have 6 domains of N protein. So as the patient's age increase, the antibody coverage, meaning the antibody produced to target various regions of the virus, is also increased. So a brief concept on neutralizing antibody. I'm sure everybody familiar with this structure already on human SARS-CoV-2 virus. And this is a spike protein. I'm sure everybody familiar with this already. And nucleocapsid protein is a protein that protect the genetic component of the virus. So in natural infection, this region, spike protein, will dock into this ACE2 protein. ACE2 is a cell receptor that exists in any human cells. So what is neutralizing antibody? Neutralizing, if you have neutralizing antibody that is produced following vaccination or natural infection, or if you had COVID-19 before, if in fact, I must emphasize here also, all antibodies are binding antibody, only a subset of antibody are neutralizing. In other words, neutralizing sits particularly at the RBD component of the virus, and concurrently and simultaneously disable the viral entry through this spike docking to the ACE2 receptor. So it prevents viral entry. Binding antibody, on the other hand, it binds to other part of the virus component. It can still disable disease, it disable the viral replication. In other words, if you don't have neutralizing antibody against spike or binding antibody against spike, the viral can still dock and release the genetic component into the host cell, but it may not be able to replicate if you have a high titer towards nucleocapsid, because by the time it enters, the viral will be dismantled by the antibody already. So I think as the current situation, we know now that following infection, people can still get infected, but it prevents the severity of the disease. So with ImmuSAFE, we can quantify both. We can quantify both IgG binding and also IgG neutralizing. So initially, when we developed this, this is just what you're seeing on your screen now is just a step on how to assay the test using ImmuSAFE. If you're familiar with the steps, they are rather similar with ELISA. It's a standard, there's a primary incubation with your sample, and then washing, and then secondary incubation with detection antibody. So when we developed this last year, we were targeting on IgG binding. But when we found out that by just adding ACE2 onto the platform, and also the cofactor of ACE2 zinc chloride, by just adding these two, we can perform simultaneously neutralizing assay concurrently with binding assay, IgG binding assay, standard antibody assay. I'm just going to skip this because it's rather technical, which I don't think should be the interest of this. But the point of this slide is that the preference of the ACE2, the receptor that I mentioned earlier, binding, it gives a better signal with full-length spike. If you remember earlier, I said we are focusing on full-length spike, although despite we have 3 other components of spike protein, but we are focusing on full-length spike, evidenced by this, because the titer, the serodenitrates you can see here, the binding of ACE2 towards full length is much greater and much more telling than only focusing on RBD. So we argue, that's why we argue that using full length spike protein is much more biologically relevant. I'm just going to skip this as well. This basically is just going to tell you that the higher your antibody is, the lower your signal against ACE2, which makes sense. You have more antibody, meaning you don't have more binding ACE2 towards spike. That's because neutralizing antibody prevents the binding between ACE2 to spike. So the assay actually measures the depletion or the reduction of ACE2 signal binding towards the full length spike. And this is a if you're familiar with other scientific journal, this is a standard invert correlation between IgG and ACE2. As I mentioned earlier, if I go back to the slide where I show this one, as I mentioned earlier, this is ACE2, this is spike, and neutralizing should sit here. So what we employ is, our platform is the other way around. We put the spike component onto the chip and we incorporate ACE2 into the assay. So what we are measuring is actually the binding between ACE2 and spike. And if you have neutralizing, the signal that excited by these ACE2 will be diminished. So the inverse correlation that I mentioned just now is that this graph, basically what this graph is telling you, the higher your IgG binding is, you should see a reduction, a linear reduction of the ACE2 signal. It's a simple concept there. Meaning if you have reduction of ACE2 signal, meaning there's no ACE2 bind towards the full length spike of the spike protein from the virus on the antigen, meaning you have higher neutralizing antibody. I'm just going to skip this as well because this is just an experimental validation. This is a slide that we used to present to IMR and also to NITI. So basically in our result, this is also from IMR data that we have. The cutoff that we use is to generate a threshold. When we compare between, there should be another graph here, which we didn't, which missing here is actually the pre-pandemic sample. So this threshold is built based on pre-pandemic. And true enough, the pre-vaccination sample that we see here, pre-vac stands for pre-vaccination, post-vac is post-vaccination. So pre-vac titer is close with the pre-pandemic titer. And as you can see, following our vaccination, the titer of neutralizing antibody increases. For this group of samples that we tested, I think there are about 284 samples here that we tested with IMR last time. So the conclusion that we can draw is, by just measuring ACE2 on ImmuSAFE, you can actually get both information on neutralizing as well as IgG binding against N and S, given the multi-antigen availability onto the platform. And because we have tested this with the viral neutralization assay by surrogating ACE2 assay on ImmuSAFE, it mimics the same observation that we have tested using the viral neutralization assay. In other words, the neutralization assay that the neutralization antibody binding titer generated from ImmuSAFE is close to mimic whatever happening biologically in vivo in real world. Meaning, if you get infected by the virus, the full-length spike that were fabricated on the array will represent the full length, the exact conformation of protein that originated from the virus that will attach to your cells. Meaning, it's a true positive result. And because it's a less laborious, so yeah, it's a simple and straightforward assay to conduct. So I think, given the current situation, I just put here the current phase 3 clinical trial vaccine candidates available currently in Malaysia. We know we already have Pfizer, AstraZeneca, which is a viral vector. We know the mRNA vaccine is Pfizer, viral vector, which is AstraZeneca, which has been approved by NPRA, Sinovac. And if I'm not mistaken, we are currently evaluating Janssen and Sputnik, if I'm not mistaken. So what results should you expect if you receive this following vaccine? So if you see in this column here, I put expected antibody response by vaccination with no prior COVID-19 infection. So when we conducted the test with IMR, there are a pool of samples. We tested the sample that has been vaccinated using Pfizer, but we saw that there are a pool of samples that are positive also for N protein. So we concluded if you found such a result, it means that okay, this patient has been previously infected by SARS-CoV-2 because as you know, the mRNA, the Pfizer vaccine encode only spike protein. So there's no way you can develop antibody against N if you receive Pfizer and if you have no prior infection. But if you have prior infection and your result shows, oh, okay, I'm positive against N as well, meaning you do have prior infection and the Pfizer boosting your antibody against S protein here. And similar for those of you who have received AstraZeneca, you should anticipate in the case if you are not in immunocompromised person, medical condition, you should anticipate an antibody titer towards S protein. In compared to these two, Sinovac, because it's a whole virus, and it's a whole virus, I have to emphasize this, the virus that they used to generate this vaccine originated from patient from Wuhan. So we know that the vaccine is actually from Wuhan strain here. So it may or may not work as well as against the Delta variant, but because it's a whole virus, it can still produce anti-N antibody response against the nucleocapsid. And as you know, the nucleocapsid from SARS-CoV-2 is 90% similar with SARS-CoV-1. So throughout 20 years, there's only 10% rate of mutation, which means you can still get protection from anti-N antibody. I know they are skeptical because they say, okay, we don't have neutralizing antibody or what's going on, are we going to get reinfected or whatever. The purpose of vaccine is to prevent disease, not to prevent infection. At this point, you can straight away tell already that it does not prevent infection because there are cases, increasing cases that shows if you receive, for example, the Israel data, they all receive Pfizer vaccine, but the percentage of people who get infected increases as well, despite after a few months they receive Pfizer vaccination, complete dose of Pfizer vaccination. But the rate of hospitalization and also the rate of people who die because of the disease are tremendously low, is insignificant at this point. So it tells you that all of this vaccine works. It works to prevent disease, but it may not work efficiently to prevent reinfection. Okay, so this is the output that you get if you test using ImmuSAFE. This is in our Syngenix format. Different centers will employ different format. And as you can see, like I explained earlier, we measure both binding and neutralizing in one assay, in one run, meaning you don't have to do two separate tests. It's just in one test. So the summary of the result is stated here. Whether you are negative or positive towards binding antibody, it is stated here. Okay, I think there's a mistake here. Sorry, my colleagues. Shirin, can you explain this is a positive, right?
Yeah, it does have like some sort of binding towards the nucleic acid, but because we are actually calculating the cumulative,
Right.
so yeah, so it's negative in overall.
Right, maybe it should positive. Oh, sorry, I accidentally skipped a slide. Alright. Okay, binding and neutralizing. You are positive. So as I mentioned earlier, we have 6 antigens on the 6 N antigens on the platform on ImmuSAFE. These 5 antigens represent a non-redundant, non-overlapping domains on the N antigen. So you are positive if you are, the calculation is based on the cumulative score of all these 5 domains. And the cutoff is stated here. You are positive if you are above this particular score. This score represents a cumulative positive titer of all 5 antigens. And this cutoff was determined by comparing true positive sample with pre-pandemic. You won't see it here because we developed it during our R&D product development R&D stages, and that threshold was determined by using samples provided by IMR, and that threshold has been agreed by us and also IMR. So what you see in the cutoff here is based on pre-pandemic samples, 100 pre-pandemic samples provided by IMR. So the readout that you will get is anti-N antibody titer for binding antibody and also anti-S antibody titer. So if you are positive in any one of these, you are considered positive for IgG binding, which is indicated here. And whereas for neutralizing, as I mentioned earlier, we're just looking at the SS full length. We call it, well, internally we call it a sector-domain trimer because it's a trimeric protein and it's a full length of the spike protein. We will change this to S full length for layman term, for easy for people to understand. And if you are positive, it will state here positive. So this line represents the positive, negative, and in between is equivocal, as stated here. So this is the cutoff that we have generated using pre-pandemic samples, and that pre-pandemic samples was provided by IMR, and this cutoff was agreed by IMR. So basically, this readout represents the reduction of ACE2 signal binding toward S ectodomain primer. 50% reduction. If I'm not mistaken, I think everyone is aware with CPAS. CPAS is another competitor or another test that commonly used to measure neutralizing antibody post-vaccination. CPAS used 20% to 30% cutoff, reduction of signal by 30%, whereas we use 50% reduction here. And the data we generated internally showed a close performance that has been reported by other vaccine manufacturers so far. And also, I think CPAS uses only one antigen as RBD, whereas we use as full length. And on top of that, we can also quantify the IgG binding that you have against these two components, N and S. So S here represents other binding antibody that does not prevent, that does not play a role in the ACE2 to spike full length interaction. So you can still have protection if you're positive against these two. Protections against disease. Let me just rephrase that. I don't want people to misquote and say, oh, you are protected against SARS-CoV-2. You are not protected against infection, but you are protected against disease severity. And that statement has been backed by a study provided by, conducted last year in Harvard, where they reinfect, I think, rhesus monkey with SARS-CoV-2 virus. They infect the monkey first with SARS-CoV-2 and waited for a month for the monkey to develop NTN, NTS antibody. And then following that, a month later, they reinfect the monkey with SARS-CoV-2 virus and they have no severe symptoms. And they observe no severe symptoms. So that is a proof that actually IgG binding is equally important as the neutralizing. Of course, ideally, you want to have an IgG neutralizing to disable the viral entry, but given the rate of mutation of the virus currently, as you know that virus mutated at every 10,000 replication. So the true question is which mutation that actually give more fitness for the virus to infect you more, to increase transmissibility. So given the rate of the mutation of the virus, meaning you may not have 100% protections against reinfection, but at least you have protection against disease severity. Similarly, this is an example of negative results. You can see some of the numbers here are in blue, but they are not actually positive because of this cutoff. This is way below the pre-pandemic cutoff. That is why we call it as negative result here. Whereas, yeah, these are all negative for all three components measured here. Yeah, I think that's all because, yeah, this is some of the marketing side of the test. And yeah, I'm happy to answer any questions you have at this point. Okay.
Thank you so much, Dr. Diana, for that very informative session. I believe that there will be quite a bit of questions that will be coming. In the meantime, what I would say is, I would also like to share with everyone to guide you how to place the order for this test. But before we go there, I think let's open for Q&A on this ImmuSAFE first. So are there any questions? You can either unmute yourself to ask, or you can type it on the message section.
Hi, I'm Mr. Tan. I'm a distributor for the ImmuSAFE. So I have a question because currently there is also the antibody test, so-called antibody test from the PATH lab. So they also mentioned that, you know, you can check your antibody level after the vaccination. May I know what is the difference between the ImmuSAFE and also the PATH lab? And from the social media also, we can see a video to say, you know, after they take a vaccine and they do the test at the PATH lab and they see there's a 0 level of the antibodies.
Yeah, that highly likely. Okay.
Customers.
Okay. Yeah, I think I get what you asked. Honestly, I get this question on a daily basis. I don't know what PATH lab used, but given the current neutralizing test that is available on the market, is either from CPAS or Siemens. So I think I know some of the outside clinic or hospitals are using CPAS. So that's an ELISA base. So the difference is that CPAS or Siemens, they give you information only on neutralizing, meaning the antibody that sits between the ACE2 and the virus. But they don't tell you the information of other repertoire of antibody that could bind other part of the virus. So you only get one information. So in clinical research point of view, clinical interpretation, the lesser component you have to interpret the data, it increased a false positive result. Whereas we rely on several components to call a sample as positive. And not only we tell you that whether you have a neutralizing antibody, we also tell you that you have an IgG binding antibody. As I mentioned earlier, binding antibody is the antibody that does not prevent the cell entry, but it dismantles other part of the virus.
All right, thank you.
Does that answer your question?
Yeah, okay, thank you.
Dr. Diana, there's another question from Tech. Is it possible to get positive on binding and negative for neutralizing?
Yes.
And vice versa?
Yes. Yeah. Like I said, okay. I think let's streamline our understanding. All antibodies are binding antibody. Only a subset are neutralizing. You can get binding antibody from vaccination from Sinovac, for example, but not from the potential. It's not from. You can still get binding from Pfizer lah, but it all depends how your antibody responds against the vaccine introduced in your body lah. But there's vice versa. There's no rule in this because I cannot tell what your body can produce. We put antigen, but whatever your body manifests, it depends on each individual. But yes, to answer that question, yes.
Okay. Good. Thank you, Dr. Diana. Any more technical questions before we move on to the next part, which will be very quick as to how you can start, raising requests? Is there a website to read the documentation you just described?
Yes, Syngenix website. Is it should Ines confirm with me? Should it? It is available in the website, right? All the because I think my colleague should it?
Yeah. The documentation. If in terms of the publications and all, yes, we do have this in our website that you can just go to the support page. There's information there you can read through, and we also have a page for ImmuSAFE test as well. You can get more information in terms of like the how to run the test and also this that. So feel free to just go through our website.
Assay protocol and all. Yeah.
Can we get the website?
Yeah, sure. Is it syngenix.com, Shirin? Yeah, maybe
Yes,
Shirin.
let me type in the website group.
Yeah, just type it in the group message, then everyone can see it. Okay, there's another question here. Does it mean that ImmuSAFE will get more accurate results compared to PathLab test?
Okay, I have no clue what PathLab test is using, but as I mentioned earlier, our test in compared to two other tests that I know that are already in the market for neutralizing antibody, we give more information. And our cutoff is based on pre-pandemic. If you ask from Syngenix point of view, yes, I would say accurate, much more accurate in compared to that other two tests, but I don't know what PathLab test is using. But it gives you more confidence, by having more information and more idea on what type of the repertoire of antibody that you have. It gives you much more confidence in the test.
Okay. There's another question from Wei. Wei, could you elaborate further? When you say lead time, you mean the turnaround time, is it?
Yes, like if we're placing order, how long we are expecting to have these products and what is the actual setup that we need to run?
I see. Okay.
And what's the country of origin for this? Because that will also incur like tax duties and all.
Okay. Country of origin, Dr. Diana, maybe you'll be able to answer that.
Country of origin as in?
For the test.
Country of origin, Malaysia. We produce 90%, if you can see behind, that's our lab. This is the microarray surveillance lab. That is the manufacturing lab where we produce all the protein.
Okay.
Yeah, but Syngenix is a British Sweden company. All of our, scientifically, the staff, the manufacturer are all Malaysians, but scientific advice comes from our, of course, CSO, Professor Jonathan Blackburn. You can see under publication in Syngenix website, you can see all of our paper will have Jonathan Blackburn's name. So he's our CSO, and this product was we will not be able to develop without his approval. Everything must be approved by Jonathan Blackburn. So to answer your question, Malaysia, but in the advice from Jonathan Blackburn and other board of directors.
Okay, so now on the other part, the test setup environment that's required. What I understand is that all the doctors need is actually just to withdraw IV blood, at least 3 ml of IV blood. What about storage condition, Dr. Diana? Does it have to be in an EDTA tube or just any plain tube?
Both. You can either use both, because we have a data show that there's no difference between using plasma or serum. In other words, anything produced in the serum will not interfere with the assay because it only captures what it needs to capture. The rest will be washed off. So that's why it doesn't matter. If you don't have a red tube, plain tube stock, you can use the purple tube stock.
Okay, so after taking the blood sample, we would advise to store it in the fridge and await collection. And to answer the question, the turnaround time at the moment, we are looking at 7 working days for the results to come up. Okay, so the next question, does the neutralizing antibody, if the neutralizing antibody shows negative, but IgG test was positive and there's 60% of level, why is there such a situation?
So IgG test as in binding, I don't think we have percentage in IgG binding. I'm not sure that 60% represent what, and we don't measure percentage. That percentage we only see in the result output by Siemens or CPAS. If you measure a reduction, that is qualitative. We measure quantitative. We extrapolate how much antibody titer that you have. We don't go by percentage. But I think I know what you're trying to ask. Why in such situation you have negative neutralizing but positive IgG binding? I think that's what you're asking. But okay, IgG binding. Then if such result is presented to me, then I will ask another medical historical or vaccination historical question to such patient. Have you been vaccinated with, what vaccine did you receive before? If you say you received Sinovac, it's not surprising to me because Sinovac is a whole virus. Similarly, if you receive vaccine from Pfizer or AstraZeneca, because although they encode mRNA against the spike, the only region that is neutralizing is the RBD. The rest of the spike, if you are positive against S, meaning it's an antibody that binds to the spike protein that can still dismantle the virus. So to answer your question, why you have this situation, I think I can't really give a definitive answer until I know what vaccine, or is this post-infection? Yeah.
The vaccine taken was Pfizer.
Pfizer.
Yes.
Positive against S or N, the IgG test. Did it mention?
Hasn't been mentioned yet.
Okay, but for Pfizer, if you don't have prior infection, my expectation is you either positive on antibody IgG against S or neutralizing, either or both. Either one of these, or you can also be positive on both, which is good, meaning you have a pool of binding antibody, and you have a subset of neutralizing antibody that will disable you from reinfection, which is good.
Okay, good.
Yeah, you maintain your lifestyle, that whatever you eat, you maintain your social distancing, which is, yeah. Next question.
Okay, the next question, I think we will answer all these questions on the screen and move on to the next section. So if this is interesting, if there is either one of the antibodies positive, can we conclude that this patient has enough antibodies?
Yeah. This is a rather
common question, I think.
Yeah, common question. I cannot enough antibody to give. Okay, there are two different things here. Like I mentioned earlier, let's streamline our understanding. enough antibody to protect you from reinfection or enough antibody to protect you against disease, progression of disease, right? Given the current situation, I don't think we can afford to choose. At this point, given the rate of the mutation is so fast, imagine that virus, the genetic component, it replicates, right? It enters, once it gets infected into the host body, it replicates. Every 10,000 replication, one mutation. Every 10,000, one mutation. That's how fast the virus mutated. But the true question is which mutation that is actually clinically relevant? So the emergence of Delta variants tells you it knows where to mutate. It knows where it get attacked by your antibody, and it mutate exactly at that point. But what your second best bet here is for me to have a binding antibody. At least if it cannot prevent the viral entry, at least it can prevent viral dismantling once it enters your body. It prevents the virus to replicate further. In other words, it prevents disease severity. You might still have some minor symptoms, mild symptoms, but it will not get you into hospital or ICU.
Okay, next one. From the slides, it mentioned that those vaccinated with whole inactivated virus, for example, Sinovac and Sinopharm, will generate both anti-N and anti-S antibodies.
Potentially, yes.
Does this mean that those who are vaccinated against mRNA vaccines will most likely not generate anti-N antibodies?
From our data with IMR, most people who has been vaccinated by Pfizer will generate a very high titer towards neutralizing antibodies, a very superior vaccine against neutralizing. But we found because the sample, when we did that testing, right, the sample was collected at 3 different time points: pre-vaccination, 3 weeks post dose 1, and 3 weeks post dose 2. And the same number of patients remains positive for anti-N. And this is like really small percentage, I think 1% of the whole tested population. So these particular patients, historically, they have already been infected by SARS-CoV-2 before. So to answer your question, will most likely not generated an antibody? Well, it's a mRNA encode against spike. Why would it generate antibody against N unless you have been infected by COVID-19 before? Unless you have been, your body has been introduced by whole virus via natural infection. But to answer, no, I will not anticipate one who has received Pfizer vaccine or Moderna vaccine to have positive against an antibody.
Okay. Does ImmuSAFE's binding antibodies, are they able to differentiate the amount of IgM, IgG, and IgA?
Hypothetically, yes. In principle, yes. But at this point, we are just measuring IgG, not IgM, not IgA. As you know, IgM is manifested 3 days post-infection. And if you know the conformation of IgM, is a big protein, consists of multiple IgG. So once IgM takes place, it will stay there for a few period of time, and then it will dismantle and differentiate it into IgG. So it is much more relevant to measure IgG because you want to know how long your IgG sustained following infection or following vaccination. IgA, no, IgA concentrated mostly on mucosal cell, meaning cells from the nasal, from the tract, the breathing tract. Yeah, so from blood, you can only detect IgG and IgM, but we do not measure IgM because that would mean it's as though you're diagnosing SARS-CoV-2, which is not the purpose of this test. This test is an antibody-based test.
Okay, here is a very important question. What is the clinical implication for this test?
Yes.
Is it necessary in clinical practice?
If you want to know whether you are protected against disease or reinfection, is it necessary in clinical practice? It depends on what the clinicians want to answer here. And also it depends on what the patient wants to know here. If you want to know whether you're positive for protection against, like I mentioned, against disease or reinfection, then yes. But if it's not necessary, but given the current situation, I think everyone is asking whether am I protected or not. Based on this current situation, I would say yes. But then again, that is just my point of view. Let me just put that disclaimer first.
Okay, the last question, asking whether the test results will be released by Sengenix. To answer that, the test will be sent to our partner lab, Neogenix, who will be issuing the results through to you. Okay, and the next question is Sengenix manufacturing facility ISO GMP accredited, and is the product MDA registered?
Shirin, if you can answer that.
Yes. So our product, we actually like produce the proteins here in our lab. We following all the GMP practice. We currently in the midst of getting the ISO accreditation as well. And then the final manufacturing part is actually conducted in the US, where we have ISO accredited lab in the US as well.
I believe it is
And then
FDA registered, right?
Yeah,
it's registered in Malaysia.
Okay, good. Okay, one last question.
Sorry, sorry, I just want to cross-check, right? Shirin, you mentioned that the assembly sounds like what happens in US, right?
Sorry?
Yeah, this will be the
Sorry.
in the US, we actually do the fabrication of the protein onto the microarray chip, microarray slides. So yeah, the spotting part.
Here
So that's also one of the.
So I'm a bit confused at whether you're actually manufacturing the whole chipsets in Malaysia or just partially, then you send to US, assembly it and re-import into Malaysia.
I can explain that. Designing of product in Malaysia by myself and my colleague, and also with the purview of Professor Blackburn. Protein expression, cloning, and everything is done here. The fabrication, the putting the protein onto the chip is done in the US.
So the final product will actually from US to come back to Malaysia, right? After you fabricate it.
Yeah. After you fabricate, you have to quickly, pack it in a -50 temperature. It cannot drop. It cannot.
Only the final part.
Yeah.
But the most important items in the chips is actually the antigens itself. Yeah. And then even when we fabrication in the US as well, it's actually using our technology, the surface chemistry and everything.
Yeah. The component from ours, what they did is we use their machine to spot.
So to answer the previous question, is the country of origin, I would say is actually from US.
No, it's actually from Malaysia. 90% of the work are done here in Malaysia, only 10% in the US. It's disregard whatever work we have done here in Malaysia if we say that is from the US.
But in the custom clearance point of view, they will refer to where is your final assembly country that you ship the final goods out. Yeah, so that is actually your examples in US, and then you ship to globally for testing or selling, right?
It actually come to Malaysia first, right, Shirin?
Yeah, so everything once we've done the printing will come to Malaysia, and then will be distributed from here.
Yeah, post-production, we still have to do the testing, post-production. Post-production testing is done here, right behind me, the lab behind me. The QC for post-production chip before we send it out, it has to be done here in Malaysia. But if that is the interpretation of where the product comes from, if it's the interpretation, then yeah, I have no further comment on that. I think we should move on to the next question.
Yeah, okay, the last question. We won't be able to know how long we are protected, even though we know the title. Is that correct?
how long we are protected, even though we know our data. Yeah, you won't be able to know. So that's why the current, what people did now, I think people test on post 3 weeks, at least 3 weeks post complete vaccination, and then 1 month or 6 months later, and then 3 months later, 6 months later, and so on and so forth, depending on how you want, what the data, what the science tells us.
Okay. Because in the previous one, it's actually just 3 months.
Yeah, but if you, yesterday it was published in Nature Communications that it depends on which study you're referring to. The recent paper that I referred to, the Nature Communications, showed that if you have prior infection to other human coronaviruses, and because these have higher genetic and component protein similarities with the SARS-CoV-2, you can still get protection up to 7 months. So the data that they publish are from 7 months, provided that you have been infected with other human coronaviruses and then SARS-CoV-2. So you will build a much bigger antibody repertoire to provide longer term protection, I suppose.
Thank you, Dr. Diana.
Okay, thank you so much for all the questions, and thank you, Dr. Diana, for diligently responding to them in detail. If there's any more questions what you call on this matter, you can actually direct it to me. Later I'll share my contact details, and then I will then pass on this question to Dr. Diana or
happy to answer
the relevant parties. Okay, so just before I close, I'll have a very quick sharing as to how you can order these tests through eMed Asia platform. Okay, so can see my slide. My slide isn't moving. Okay, so the most important thing that needs to be done in order for you to how to say, be present in the market is to do your profile update. So when you log on to emadasia.com, for patients, they can actually see this search function where they want to see a doctor for clinic search, and you can see we also have an option here for the SARS-CoV-2 neutralizing antibody test. Okay, so when they choose that, based on their current location, your clinic will be visible. So now the question is how to make your clinic visible to these patients. When you log into emadasia.com, this is the front page that you will see. On the top right corner, you see clinic scheduling. Click on that. Go to edit your clinic profile. So the most important thing to remember to take home here is edit clinic profile. Okay, you need to click on edit clinic profile, and when you scroll down, you see all the services available. So of course, the more you check off, then you'll be quite more visible. And you can see that there's the option there at the bottom left, where there's the SARS-CoV-2 neutralizing antibody test. And another thing that you can update here is also for all the other tests that you run and the pricing that you will be charging the patients. This is actually another very innovative thing that another innovative product that eMed Asia has come up with, where we can direct patients who do not know which clinic to go to for tests to you just through the search function. Okay, so how do you order ImmuSAFE? Again, after clicking on what you call clinic scheduling, you scroll down on the left-hand side, the menu bar, you would see laboratory works, others. So if you choose laboratory work COVID-19, that will bring you to RT-PCR test. So under others, you will see what you call this ImmuSAFE. So after clicking on others, you want to click on new lab test request, and it will bring you to this page where you can actually order either ImmuSAFE antibody test, or there's another thing that we also have is a HPV DNA testing. Okay, so but what we are talking about now is the ImmuSAFE antibody test. So the steps are quite straightforward. We also have a video guide available. You can also contact me on how to go around this. So what you are looking at here is if a patient were to request for an appointment through the clinic search function, all you need to do is to accept this patient's request, all right, on the right hand side. And if you have a bulk, what you call this, a request, we also, the improved version of the website, you can just do a bulk approval based on this. Okay, and after that, after taking the blood sample, you just need to go to all lab test requests. This of course after you have already accepted the patient's appointment, and download the request form. After downloading the request form or downloading multiple request form, we have a checkbox where you can just check out and download all the request forms, right? And after that, you just print out this request form, and this is equivalent to you know what we have traditionally been doing, filling in the carbon copy forms. So you just need to insert this form together with the blood sample and hand it over to the logistics partner. Right. So upon completion of the test results, you will receive what you call this the test result, and the patient also will receive a notification that the test results are already available. The patient will not receive the results; they'll just receive a notification that the results are available with the doctor. Okay, and the doctors are able to then also look into the history and track what status the test sample is at, whether the sample has been received, whether the sample is being processed, and even up to completion. So upon receiving the report, from what I understand, our partner lab, Neogenics, they do also send you a PDF copy of the lab report through email, but you can also download the report through ImmuSAFE Asia platform. Okay, and with that, that concludes my sharing session, and this is my contact details. So if you have any inquiries, any questions, whether it is regarding referring patients to the for the test, or even the more technical questions, you can direct it to me, and I will direct it to the rightful party where you can get the best answer. Okay, so with that, I thank you very much for joining us today, and I think I will close the session now. Thank you for dialing in, ladies and gentlemen, doctors. Take care. Have a good weekend.
Likewise. Thank you, everyone.
Bye-bye.